Welcome to the deep dive. Today we're tackling something really important, the use of hyperbaric oxygen therapy, HbO2,
Right.
specifically how it helps heal tissues damaged by radiation. We're focusing quite a bit on folks treated for head and neck cancer and how HbO2 can be, well, a real game changer, especially if surgery is needed later.
Absolutely. It's a critical area.
So our mission for you listening is to get a handle on why radiation damage is so tricky and then how exactly HbO2 steps in to help. We're basing this on chapters from the textbook Hyperbaric Medicine Practice, a really solid source.
It is very comprehensive.
Okay, let's dive in. What makes radiation injuries so uniquely challenging to deal with?
Well, the crucial thing to understand, even with super precise modern techniques like IMRT, intensity modulated radiation therapy.
Yeah, the ones that really try to just hit the tumor.
Exactly.
Yeah.
Even then, some of the surrounding normal healthy tissue gets caught in the crossfire. It's somewhat unavoidable collateral damage. And it's not like all healthy cells react the same way. The lining of blood vessels, the endothelium, quite sensitive. Then you've got fibroblasts. They make connective tissue, vital for healing.
Right.
They're next most sensitive, generally. Muscle, nerves, a bit tougher, but still, they can all take a hit.
So it's a spectrum of damage, really, not just killing cells outright.
Precisely. Some cells might just die. Others get damaged and die later. Some, well, they survive, but they're sort of incapacitated. They can't divide, can't make good collagen.
Or the collagen they do make is faulty.
Yes, exactly. Or defective enzymes. And over time, this all adds up. The sources clearly show this progressive loss: fewer blood vessels, so less vascularity, and fewer healthy cells, so less cellularity. It's a downward slope, really, as shown in Figure 1 in the text. This is the core problem HbO2 tries to fix.
And that leads to what the literature calls 3H tissue, right? Hypovascular,
Low blood flow,
hypocellular,
fewer cells.
and hypoxic.
Yeah, starved of oxygen. It's really the perfect storm for poor healing. Radiation can cause these tiny clots in the small vessels, making blood flow even worse.
So this 3H situation isn't static, it gets worse over time, like figures 2 and 3 show.
It does, unfortunately. It creates this long-term vulnerability.
Yeah.
So years down the line, that tissue is still compromised. It might break down on its own spontaneous radionecrosis, or if you need surgery there, healing becomes a massive challenge.
Okay, so that's the hurdle, this oxygen-starved, cell-depleted tissue. Now, how does hyperbaric oxygen, breathing pure oxygen under pressure, how does that actually help? It's the oxygen, not the chamber itself, correct?
Absolutely correct. The chamber is just the delivery device, essentially. It lets us push much more oxygen into the blood than you could ever get breathing it normally.
Right.
And interestingly, the animal studies show that just breathing 100% oxygen at normal pressure, 1 atmosphere or 1 ATA, it just doesn't cut it.
It's not enough.
Doesn't seem to be enough to kickstart new blood vessel growth, angiogenesis, or the production of that connective tissue fibroplasia in these already damaged tissues. Figures 4 through 7 illustrate this point pretty well.
So a bit more oxygen isn't the answer. You need the pressure component.
That seems to be the key.
Yeah.
You need that pressure to dissolve significantly more oxygen into the plasma, forcing it into these tissues that are struggling to get enough. Research points to 2.4 ATA as being in that therapeutic sweet spot.
2.4 ATA. Why that specific pressure?
It appears to provide enough of an oxygen boost to stimulate healing without pushing into the territory where oxygen toxicity becomes a major concern, especially with repeated treatments.
Okay, and this is where it gets really interesting. The sources show that HbO2 at this pressure actually stimulates angiogenesis and fibroplasia in head and neck cancer patients post-radiation. We have direct evidence, like from biopsies, figures 8 and 9.
We do. You can literally see the difference under the microscope. Biopsies taken before and after a course of HbO2 show new capillaries forming, more collagen being laid down. And using tissue oxygen measurements, plus the animal models, we've mapped out the timeline. Figure 10 gives a good overview.
And it's not an instant fix, I take it. What does that timeline look like?
No, definitely not instant. A typical course is 20 sessions, usually 90 minutes at 2.4 ATA, 5 days a week.
Okay.
And in the first phase, maybe the first, say, 6 to 8 sessions, you might not see dramatic outward changes. This is sometimes called the lag phase.
But things are happening underneath.
Oh, absolutely.
Right.
Microscopically, you see the beginnings, capillary budding, fibroblasts starting to produce more collagen, macrophages, those important immune cells, get more active, endothelial cells start multiplying, the groundwork is being laid.
So even if it doesn't look like much is happening yet, the biology is shifting.
Exactly. Then, after about 8 sessions, you enter what we call the rapid rise phase. Now you start seeing functional capillaries growing actual tubes for blood flow.
Ah, so the plumbing starts getting built.
That's a great way to put it. Tissue oxygen measurements start to climb noticeably. It's like the existing vessels are branching out, multiplying geometrically.
So HbO2 gives that initial push, letting the body's own healing restart in tissue that was basically stuck.
That captures it well. This rapid growth phase continues up to about the 20-session mark. Then it tends to plateau.
Plateau? Why does it stop?
Well, the tissue usually reaches about, say, 75 to 85% of the blood vessel density you'd see in normal non-radiated tissue. At that point, the stimulus that was driving the angiogenesis seems to naturally wind down. Macrophage activity decreases, less capillary budding, less collagen synthesis compared to the rapid phase.
And this effect lasts.
Remarkably so. Studies show this improved vascularity holds up for at least 4 years. And anecdotally, surgeons report that even decades later, tissue treated with HbO2 heals much more like normal tissue.
That's incredible. But it doesn't supercharge healthy tissue, right?
No, and that's key. It doesn't cause overvascularization in healthy areas. The effect seems targeted to where it's needed, those compromised hypoxic zones. The body's normal controls are still in effect.
Makes sense. Okay, so knowing how it works, what are the standard treatment plans, the protocols, especially when surgery is planned in radiated tissue?
Right. Based on that timeline in Figure 10 and, frankly, decades of clinical experience, the most effective approach is generally the 2010 protocol.
2010, what's that mean?
It means 20 HbO2 sessions before the surgery, then the operation itself, followed by 10 more sessions after the surgery.
Ah, preconditioning the tissue, then supporting the healing.
Exactly. It prepares the tissue bed and helps it cope with the surgical trauma and heal afterward.
And the standard session is 100% oxygen, 90 minutes, 2.4 ATA. Are there acceptable tweaks to that?
Some places might use 2.0 ATA, but extend the time to 120 minutes. That seems to be clinically acceptable, though maybe not quite as studied as 2.4.
What about higher pressures, like 3.0 ATA?
Higher pressures might give a stronger tissue response based on some animal data, but the risk of oxygen toxicity, like seizures or lung issues, goes up significantly with repeated exposures. So 2.4 ATA really remains the standard for this kind of multi-session therapy.
And doing sessions more often, like twice a day, any benefit there?
Generally not recommended. There's no strong evidence it helps more, and you might argue the tissue needs that time between sessions to actually respond to build those capillaries. The established protocols seem to work best.
Okay, 2010 is the go-to for surgery prep. Let's dig deeper into the how again. How does this extra oxygen under pressure actually flip the switch for angiogenesis and fibroplasia? What's the biology?
It's actually quite elegant, and it ties into how normal wounds heal. Work by researchers like Knighton, Silver, and Hunt showed that steep oxygen gradients are key signals in normal healing.
Gradients, meaning differences in oxygen levels.
Exactly.
Yeah.
In a typical cut or injury, you have the low oxygen center of the wound right next to relatively well-oxygenated normal tissue. That sharp drop-off, that steep gradient, acts like a beacon.
A beacon for what?
It attracts macrophages, those immune cells we mentioned. They swarm to the area, and they release growth factors, things like VEGF and BFGF.
Vascular endothelial growth factor and fibroblast growth factor.
Right. And those factors are the direct signals telling blood vessels to sprout new branches and fibroblasts to start making collagen. It's the gradient that kicks it all off.
But in radiated tissue, the damage is diffuse, so no steep gradient.
Precisely. The injury is spread out. You get these shallow gradients, maybe less than a 20 millimole Hg difference across the area. It's just not enough of a signal. The body doesn't really see it as an urgent wound needing that robust angiogenic response. Figure 12 illustrates this well.
So the body's natural alarm system isn't triggered. How does HbO2 fix that? It sounds like it's almost tricking the system.
That's not a bad way to put it. See, when you flood the system with oxygen at 2.4 ATA, the oxygen levels rise everywhere in the damaged tissue and the adjacent healthier tissue, maybe 7 to 10-fold higher oxygen tension. So those small, insignificant differences in oxygen level that were already there, suddenly they get magnified enormously. HbO2 transforms those shallow gradients into steep ones.
Ah, so you artificially create the signal the body needs to see.
Exactly. You create the steep gradient that screams, wound here, needs fixing, and then the normal biochemical cascade takes over. Macrophages come in, release VEGF, angiogenesis starts.
And the growth comes from the edges inward. following that gradient.
That's what the evidence suggests, yes. Figures 13, 14, and 15 show how these gradients change over the course of treatment, moving centrally as new vessels grow in from the better oxygenated periphery. By 20-24 sessions, those steep gradients are often gone.
Because the new blood supply has eliminated the hypoxia that created them.
Correct. The tissue is revascularized, the oxygen levels have evened out, and the stimulus for more vessel growth naturally shuts off.
And it stays under normal control, so no runaway vessel growth.
Right, it's still regulated. And this gradient mechanism also explains why HBO2 helps other compromised wounds, diabetic ulcers, crush injuries, failing flaps, where you often lack those natural steep gradients.
But not so much for a normal, healthy wound.
Generally, no. A healthy wound already has a steep gradient. Adding more oxygen doesn't necessarily enhance the angiogenesis stimulus that's already there and working optimally. It's the gradient that's key.
Fascinating. Okay, so we get the mechanism. Let's look at specific clinical uses now. Starting with jaw reconstruction, bony reconstruction. The source material makes this sound like a huge area of impact for HBO2.
Oh, absolutely. It revolutionized it.
Right.
Early on, they tried using HBO2 after surgery in radiated jaws, and the results were, well, disappointing, pretty inconsistent.
Right.
But shifting to preoperative HBO2, using that 2010 protocol, that was the game changer. It made outcomes predictable, functional.
Predictable how? What were the success rates like?
Before widespread pre-op HBO2, success for major jaw reconstruction in radiated fields meeting really tough criteria was maybe 40–50%. Pretty poor odds.
Yeah, that's not great.
With the 2010 protocol, those success rates jumped to 90–93%. We're talking restoring shape, size, function, readiness for dental implants, long-term graft survival. Tables 1 and 2 in the text really lay out these criteria and results.
A massive difference. And controlled studies back this up. Figures 16 to 18.
Definitely. Large studies comparing patients who got the 2010 protocol versus those who didn't. Complications were way down in the HBO2 group, think 8% versus 23%. And success by those strict criteria. 93% with HBO2 versus only about 62% without. It's stark.
And the reason it works so much better is the induced angiogenesis and fibroplasia, right? Supporting the bone graft, figures 19 and 20.
Exactly. It creates a much healthier, more vascular bed for the graft. This means better survival of the transplanted bone cells, better production of new bone matrix, better remodeling over time. You even get better formation of the endosteum and periosteum, the inner and outer linings of the bone, which helps the graft really integrate and last.
Okay, what about soft tissue flaps? Often needed after cancer surgery and radiation. These flaps bring their own blood supply, so why is HBO2 still needed?
That's a great question. Yes, the flap brings blood to the reconstructed area, but it doesn't magically fix the surrounding radiated tissue bed that it needs to heal into.
Ah, so it's about the interface, where the flap meets the old radiated tissue.
Precisely. And also, if there's a bone graft underneath the flap, you still need that 2010 protocol to prepare the recipient site to support the healing between the flap edges and the radiated tissue and ensure the bone graft takes, if one is used, it's preparing the soil for the new seed, so to speak.
And do we have data showing it helps with flaps, like tables 3A, 3B, 3C, and figures 21, 28?
Yes, randomized studies show significant reductions in complications like wound breakdown, infection, and generally delayed healing when the 2010 protocol is used for flap surgery in radiated areas.
So fewer problems post-op.
Fewer problems, which means shorter hospital stays, less need for more surgeries, better cosmetic and functional outcomes, and ultimately it actually reduces the total cost of care, even though HBO2 itself has a cost.
Makes sense. Now, tooth removal. The text calls this the most common cause of osteoradionecrosis, ORN. Why is pulling a tooth in a radiated jaw so risky?
Because extracting a tooth creates trauma, a wound in the bone. In heavily radiated bone, that 3H tissue just doesn't have the resources, the blood supply, the cells, the oxygen to heal that wound properly.
So the extraction site just doesn't close.
It often fails to heal, leaving bone exposed. This can then get infected secondarily, leading to ORN, this really nasty condition of dead, exposed, non-healing bone. It accounts for something like 89% of trauma-induced ORN.
But there was a key study back in 1985, right? Looking at HBO2 for prevention. Table 4, figures 2934A.
Yes, a landmark study compared patients getting teeth pulled from heavily radiated jaws. One group got just antibiotics, the standard at the time. The other got the 2010 HBO2 protocol, but no antibiotics.
And the results?
Striking. The antibiotics-only group had almost a 30% rate of developing ORN, the HBO2 group. Only about 5%.
Wow. Huge difference.
Huge. And because of that study, the 2010 protocol basically became the standard of care for extractions in radiated fields. More recent data from nearly 1,000 patients shows an ORN rate of less than 1% using the protocol. It really works for prevention.
Okay, what about dental implants? Osseointegrated implants. Can they even be done safely in radiated bone?
It used to be extremely risky, high failure rates, and a significant risk of triggering ORN, like Figure 34C shows. But again, HBO2, specifically the 2010 protocol, has made it much more feasible.
What kind of success rates are we talking about now?
Data from our center, looking at over 2,000 implants placed in radiated bone using the 2010 protocol, shows about an 84% success rate, meaning the implant's integrated and could be functionally loaded long-term.
84%. How does that compare to non-radiated bone?
It's lower. Healthy bone typically sees success rates over 94%, so radiation still has an impact, likely fewer healthy bone-forming cells, osteoblasts, surviving even with HBO2.
So HBO2 helps, but doesn't completely erase the radiation damage for implants. What's its main benefit then? Figures 3539b.
The main value is probably less about maximizing the osseointegration percentage itself and more about creating healthier soft tissue healing around the implant fixtures and drastically reducing the risk of ORN occurring as a complication of implant placement. That's the big win.
Got it. Prevention of ORN is key. Let's actually talk about ORN itself now. The source material defines it differently than maybe older ideas. It's not mainly an infection. Table 5, figure 35.
No, that's the crucial shift in understanding from back in 1983. ORN isn't primarily an infection. It's a wound healing problem. Radiation creates that hypovascular, hypocellular, hypoxic tissue.
The 3H tissue.
Right. And then some kind of trauma, or sometimes nothing specific, causes that compromised tissue to break down. And because it can't heal itself properly, you get this chronic, non-healing wound with exposed bone. Infection is often secondary, opportunistic.
So treatment isn't just antibiotics.
Absolutely not. Treatment requires removing the dead bone surgically and using adjunctive HBO2 to improve the health of the remaining tissue so it can heal.
And the sources describe different types, right? Based on the trigger, figure 40.
Yes, broadly 3 types. Type I is when radiation and trauma are close together, like a tooth pulled right before or during radiation, or jaw surgery near the time of radiation.
Okay.
Type 2 is also trauma-induced, but it happens years later. Pulling a tooth, a biopsy, even denture irritation in that old radiated field triggers it.
Right.
And type 3 is spontaneous, no obvious trauma, often linked to higher radiation doses, maybe newer techniques like IMRT or combined chemoradiation, usually shows up 6 months to maybe 2 years after treatment.
And figure 41 sort of maps out the underlying radiobiology, showing how damage accumulates and how trauma can push it over the edge into clinical ORN, while HBO2 can help pull it back.
Exactly. It also shows that concept of a golden period, maybe the first 4 months or so after we... And some surgery might be possible without needing HBO2.
But once ORN is established, the treatment protocol is different. It's the 3010 protocol. More HBO2 up front.
Yes, because you're dealing with an active, non-healing wound in severely compromised tissue. The standard approach starts with 30 pre-surgical HBO2 sessions. It's a staged protocol.
Staged. How does that work?
Okay, stage I is for exposed bone that's been there over 6 months, but maybe not super extensive. Figure 43. You do the 30 HBO2 dives. Then you assess. Does the bone look softer? Is there healthy granulation tissue forming? Is inflammation down? Figure 46.
And if it responds well.
If it responds, the surgeon removes just the softened, clearly dead bone, figure 47A, 47B, and the patient gets 10 more post-op HBO2 dives to help heal. If it doesn't respond well to the initial 30 dives, figure 48, they move to stage 2.
What happens in stage 2, figures 49, 51?
Stage 2 means a more definitive surgery, usually removing the exposed bone through the mouth, a peripheral resection, trying to keep the jawbone continuous if possible. Then they get the 10 post-op HBO2 dives. If that works, great, figure 52. If not, or if the disease was really bad to begin with, they go to stage 3.
And stage 3 is for the most severe cases. Fistulas, fractures, big chunks of dead bone, figures 44, 46.
Yes, or failure of the earlier stages. Stage 3 often involves a continuity resection, removing a full segment of the jawbone, figures 53, 55. Then reconstruction with plates, screws, figures 56 to 59, often needing vascularized flaps to bring in healthy tissue with its own blood supply for closure. And then they finish their final 10 HBO2 sessions.
And then later maybe reconstruct the bone itself, figures 61, 63.
Usually, yes. Bony reconstruction might happen about 3 months later, once the soft tissues are well healed. And importantly, because the initial 3010 HBO2 protocol helped prepare the tissue bed, they typically don't need more HBO2 for that secondary bone grafting surgery.
That's quite a process. The source material also looks at the cost. ORN sounds expensive to treat. Table 6.
It is very expensive no matter how you slice it, which really underscores the importance of prevention. Good radiation planning, pre-radiation dental care, using that 2010 protocol when you anticipate surgery in a radiated field.
And in terms of treatment costs, what's the most costly approach?
Ironically, the approaches that don't work well end up being the most expensive long-term. Trying to manage it with just antibiotics or just HPO2 without surgery, the resolution rates are low, requiring prolonged care, repeated treatments, hospitalizations. It drags on and costs mount.
So doing nothing surgically or doing HBO2 without removing the dead bone is actually more costly.
In the long run, yes, according to this analysis. The staged protocols, combining surgery with the 3010 HBO2, have the highest resolution rates. Even though the initial surgical and HBO2 costs might seem high, they are ultimately more cost-effective because they fix the problem. Stage 3 is the most resource-intensive within that protocol, but still often less costly overall than the failed conservative approaches.
Plus the intangible benefits.
Absolutely. Getting patients healed, functional, back to work, improving their quality of life, you can't put a price tag on that.
One last really critical area, the relationship between HBO2 and cancer itself. Is there a risk that flooding the tissue with oxygen could, stimulate any leftover cancer cells or cause new ones, especially in head and neck patients who are already at risk?
A crucial question, and a concern that comes up often. These patients do have risks of recurrence or second primaries, especially if they continue smoking. And sometimes, residual cancer is found when patients are referred for ORN treatment, about 4% in one series.
So what does the research say? Animal studies first, figures 64 and 65.
The animal studies are, well, kind of surprising. Using a hamster cheek pouch model, which is common for oral cancer research, some studies found HBO2 actually seemed to suppress the development of dysplasia, those precancerous changes, and delayed cancer from forming.
Suppressed it. That's counterintuitive.
It is. Tumor growth rates, once cancer developed, seem similar between HBO2 and control groups in some studies. Another study found similar suppression, but noted larger tumors in the HBO2 group, though growth rates weren't measured directly there. Other animal work, like by Nemiroff in mice with lung tumors, showed no acceleration of growth or metastases with HBO2.
Any theories? Why?
One idea is that the oxygen radicals produced during HBO2 might actually have some anti-tumor effects, maybe more effective against tiny clusters of cells or dysplasia than established tumors. But it's complex.
Okay. Animal studies are intriguing, maybe a bit mixed. What about humans? Table 7.
The human data is really the most important here. Large studies have followed head and neck cancer patients, comparing those who received HBO2, usually for reconstruction or ORN, versus those who didn't.
And the results?
Looking at over 800 oral cancer patients in one major analysis, with about half getting HBO2, there was absolutely no statistically significant difference in cancer recurrence rates between the HBO2 group and the non-HBO2 group across all stages of cancer. The p-value was 0.82, meaning extremely unlikely to be a real difference.
So the clinical evidence in humans is reassuring.
Very reassuring. The data strongly indicates that HBO2 does not accelerate cancer growth or cause more cancers to emerge in this patient population. It seems safe to use from an oncologic standpoint.
Okay, so let's try and pull this all together. HBO2, hyperbaric oxygen, is clearly a powerful tool for managing radiation tissue damage, particularly in the head and neck.
Definitely.
It helps healing after surgery in those tricky 3H tissues and is vital for treating ORN. It works by basically creating oxygen gradients that kickstart the body's own healing mechanisms.
Precisely. Leveraging natural processes.
And critically, the evidence suggests it's safe regarding cancer recurrence risk.
That's the current understanding, yes. A valuable therapy with a good safety profile in this context.
So thinking about how much this can improve healing, function, quality of life, it really makes you wonder. What needs to happen to make sure HBO2 is better integrated into standard cancer care pathways and truly accessible for every patient who stands to benefit? That seems like a really important next step to consider.
A very important point indeed. Availability and integration are key.
Absolutely. Well, thank you for breaking down this complex topic with us today.
My pleasure.